know some of the pitfalls that you can get into, as well as how to detect a pneumothorax in free air. And this, I know, is a problem because it's a problem for our technologists in this hospital, and it drives me absolutely crazy every weekend that I'm on call, but because it's like reinventing the wheel. Limitations of bedside radiography. As you all know, unlike, and this is a big learning problem for house staff and for other physicians who are used to seeing upright PA chests, things are different when they're done at the bedside. You got a 40-inch FFD, if that, maybe it's even closer. It's an AP projection. I don't know about your patient population, but in our patient population, most of the patients are really, really big. And since you don't have gravity helping you to move the diaphragm down, the diaphragm's got to move all those chitlins out of the way by itself, and it doesn't do a very good job. So things look fundamentally different in the ICUs with bedside radiography. So it comes down to being pretty much just a survey of lines and tubes, and trying to read subtleties into the lungs is very, very difficult. Besides which, you can go to, if you've got a PACS system and a digital system, you can go to the processor or the image processor and make it look like anything you want it to look like. So it's not like seeing an upright PA chest at 72 inches. What I have to explain to medical students and to house officers is it's different because it's a PA or AP projection rather than a PA projection. And one of the differences is shown in this slide. If you have an object of known size and you have a fixed film focal distance between your source of X-rays and your image receptor, the further away that object is, the more the geometric magnification. Now, I know this is old hat to you. You all understand this, but remember, I'm giving this presentation to house officers and to medical students who don't understand the techniques that we use and why this is important. So if you're talking about looking at heart size and you're talking about an AP chest, the heart's further away from the image receptor, it's going to look bigger because of this. Position. And when we're talking about position, we're talking about the position of the source of the X-rays relative to the image receptor and not the position of the patient, okay? In this situation, I've got an object of known size that is a fixed distance from the image receptor, but now the variable is how close the source of X-rays are to the object being imaged. And the closer you bring that in, the more the geometric magnification. Okay, so two parameters that are a function of the patient position, the position of the image receptor, and the source of X-rays that affect magnification in the appearance of the chest are the position of the X-ray tube, it's closer to the object being imaged, and the fact that in most cases when we're talking about the heart, it's further away from the image receptor than you would see with a PA chest. And then lastly is the fact that because patients are recumbent and they don't have gravity helping them, they don't take in as deep a breath, even if they're breathing spontaneously. The lungs are not as well inflated. That accentuates the appearance of the heart. Here is a patient, this was an upright film, but it's done in full expiration. And contrast that to this appearance. This is a patient, same patient, 2 minutes apart, full inspiration. Look at the difference in the appearance of the chest film, of the heart on the two exams. Looks vastly different. And you also notice that down here at the lung bases, the vascular markings are not quite as crisp, and that's what you would expect because the air has been pushed out of the lung bases. So lots of things going on that affect the appearance of the heart and the chest. The support devices that we're most commonly going to encounter, the endotracheal tube is probably the most ubiquitous. Everybody who's intubated in this hospital gets at least one film per day. There's just no way to avoid it. And in fact, you don't even have to be intubated. If you're in the ICU, you're probably going to wind up getting a film. Nasogastric tubes, feeding tubes, and I put in CBPs and PICCs just because they're so ubiquitous that you need to have some idea of where they ought to be properly positioned. Swan-Ganz catheters. You all know about Swan-Ganz catheters? Okay, we're going to talk about those a little bit. This is something you may not have encountered before, the intra-aortic balloon pump. And I'll show you examples of these, and we'll talk about what that does and why it's useful. The problem is the clinicians know the patient has the intra-aortic balloon pump because there's this god-awful thing sitting next to the patient's bed. But when you're looking at the radiograph, all you see is a little teeny tiny radiopaque marker at the end of the balloon pump. And if it's not inflated, it can get lost in all the clutter from his or her surgery. I put pacers in just for completeness sake, remembering who I'm talking to. Most of the time it's going to be medical students and house staff. But practically speaking, the electrophysiology fellow or the cardiologist is going to do all the determinations on that, and then they'll get a film to document position so they can see whether or not it migrates. That's generally not a problem you'll have to deal with. This is something you may or may not have seen. How many of you have seen a patient with a Sengstaken Blakemore tube in? Or even know what I'm talking about?
Is it a drain?
No, it's not a drain, but we'll talk about that. Chest tubes, all the surgical ICUs, you're going to have patients with chest tubes. And then this I put in just because if you've not seen it before, it can be confusing. It's the intraosseous infuser. How many of you have encountered that? It's becoming more and more common as first responders are utilizing that. And I've got an article in the handout at the very back about the intraosseous infuser. But basically what it is designed to do is you take this device and with 70 pounds of force, you slam it into the sternum and it goes through the anterior cortical table into the marrow space of the sternum, and it allows you to rapidly infuse fluids for resuscitation. The problem is if you've got a really big patient with a lot of adipose tissue anterior to the sternum, those prongs are not long enough to get into the sternum. But in the military application, we were talking about largely a young, healthy, fit group, it's life-saving because you can have a first responder who comes up and goes wham, and they don't have to worry about trying to get a line in a femoral vein or an artery that they can't palpate because there are no pulses to speak of, and you can rapidly infuse a lot of fluid. Endotracheal tube. Holly, if I flex the head like so, which way does the tube move? Does it move up or down?
I'd say up.
Okay. Steve, what do you say? All right, the first vote of the evening. How many hands? Let's see hands for up.
I've changed mine.
Holly, you said up. You got to vote.
Well, I didn't know how to vote if I made
Yeah, no. You have to vote.
Okay.
All right, hands for down. Okay, the thing that's confusing about that is you have to remember where the pivot point is on the skull, and it's posterior to the endotracheal tube. So if you think of it that way, when you lift the chin up, the tube goes up. When you put the chin down, the tube goes down. And that can be as much as 2 centimeters in either direction. So as a result, when you're looking at endotracheal tubes, you want that tube tip to be a minimum of 2 centimeters above the level of the carina, so you don't selectively intubate one side or the other by passive movement of the head. If the physician comes in and passively flexes the head, then that tube can go down into the mainstem bronchus. And this is that film we saw earlier, the full inspiration film, but what I've done is I've just sort of grease penciled in where the lowest point ought to be, and I use as the upper limit of acceptability the superior aspect of the clavicles. Now, what might be the problem of the tube being too high? Obviously, if it's really too high, then you're extubated. But other than that.
Not properly diffusing air.
If you're too high, the cup on that endotracheal tube is at the level of the vocal cords. And if you've got an endotracheal tube in for 2 weeks or more, and then you get extubated, and that's been sitting there for a couple of weeks, you're going to sound like this when you try to talk. Okay, so that's one of the other things you have to look at, is that it's not too high. The other thing that is important to look at when you're looking at endotracheal tubes, and I think I've got an example of this later on, but looking at the degree of distension on that endotracheal tube cup, it shouldn't be any wider than the lumen of the airway. If it is, then you're compressing the tracheal mucosa and the arterial supply and venous drainage, and that sets up the possibility of post-intubation strictures. And it's one of the things that is almost always overlooked by house staff and by some of my colleagues, is that they just don't focus on the fact that the balloon is overdistended, and you can easily overdistend these to greater caliber than the airway, because remember, the posterior portion of the trachea is membranous, and so you don't appreciate just how far that balloon has distended it posteriorly. Nasogastric tube and feeding tubes. In this hospital, some years ago, we developed a protocol for how to place a feeding tube in a patient who was intubated or had an impaired gag reflex. Unfortunately, I wasn't involved in making this decision, or we might have done things a little bit differently, and I'll show you why in a few slides. Does your hospital have a protocol for that, for feeding tube placement in? Okay, it's one of the things you want to be aware of, because it's very easy to pass one of these feeding tubes past that balloon on the endotracheal tube and put it out into the lungs. And so if the tube is just passed willy-nilly without checking the position of the tip, it can go right out into the pleural space, all the way through the lung. The problem with this particular protocol is if you advance the tube, but the radiopaque tip is proximal to the level of the carina, you don't know whether it's in the airway or in the esophagus. So this would not have been my choice of what to do in terms of shooting an AP film. You do a left anterior oblique, and that puts separation between the esophagus and the airway, and I'll show you an example of that. Swan-Ganz catheter. This is something that you see most commonly in the thoracic surgery ICU and in the CCU. The catheter is inserted from either a femoral venous approach or a jugular venous approach. And it's used, when it's placed in the pulmonary artery, you can use it to monitor cardiac output. You can do thermodilution, inject cold water, and then measure how much output you're getting from the right heart. You can use it to monitor pressures. Or if you inflate the balloon and let it wedge in the pulmonary artery, you can read pulmonary venous pressure, which is a reflection of left atrial pressure, which is a reflection of left ventricular end diastolic pressure. And that's where it's used most commonly in the CCU. As the patient is getting all these different drugs to try and improve their cardiac function, as the cardiac function improves, LVEDP will drop. And so by having a wedge pressure that you can monitor, you can see how effective your medical administration has been. So where do we want this tube? This is a real simple approach to where the tube tip should be. Divide the lung into thirds vertically and into thirds horizontally. If the tube tip is in this block or this block, it's okay. If it's anywhere out here in the periphery, it's too far out. And when we get to complications, I'll talk to you about what the potential complications are. The intra-aortic balloon pump. Anybody ever seen a radiograph and know that you were looking at an intra-aortic balloon pump? This is a new concept for all of you. All right, let me just take a minute to explain this. This is what it looks like. That's all you see if the balloon is deflated. Here it happens to be inflated at this point in time. But it's only inflated for a brief period. Most of the time it's spent, I take that back. It's inflated for the longer period of time, but it can be instantly deflated with appropriate signals on your electrocardiogram. And the idea of this thing is to increase coronary perfusion. And I'm going to have to do a little board work here to explain this to you. Okay, now this, if I lose you in my explanation, speak up, because this is pressure, and this is the typical profile of pressure in the aortic root. This is the point where the aortic valve opens. What determines coronary artery perfusion is mean diastolic pressure in the aortic root, because once the ventricle has completed its contraction and injected the blood out into the aorta, then the aortic valve closes, and your pressure in the aorta is a function of how much blood you have running off into the abdominal viscera and to the extremities. So if I inflate the balloon such that I decrease diastolic runoff, in other words, as soon as the left ventricle has completed its contraction, the aortic valve closes, I inflate that balloon so that blood can't run off into the abdominal viscera and the lower extremities, then I change this curve in the ascending aorta to look something like this. That means mean diastolic pressure goes up. Coronary arteries are perfused during diastole, not during ventricular systole. So I've increased the coronary artery perfusion pressure. Everybody with me? Now the other thing that happens is, since I now have a balloon that's in the descending thoracic aorta that's really an obstruction to blood flow, if I suddenly collapse that with the onset of ventricular systole, pressure drops like that. Because you've taken something that was occupying space in the descending thoracic aorta and you rapidly collapse it, so pressure has a sudden drop. What that does is it lowers the point where the aortic valve opens. So it decreases the pressure that the left ventricle has to contract against to eject blood. So you've done two very important things. You have decreased the oxygen demand on the left ventricle by lowering the pressure at which the left ventricle has to contract against to eject the blood from the ventricle into the aortic root, and you have effectively raised the diastolic pressure by decreasing diastolic runoff to the abdominal viscera and the lower extremities, so you increase coronary artery perfusion. That's what it's designed to do. Does that make sense? Did anybody follow what I was just saying?
Yes, sir.
Okay. It took a second for us to get back in the sync with the machine, but suffice it to say, from this little radiopaque marker, if you've had somebody who's had coronary artery bypass surgery, and they've got sternal sutures through here and lots of hemoclips, that can get lost. And you don't recognize that, in fact, there is an intra-aortic balloon pump. Where you want this tip is right below the calcium in the aortic arch. You don't want it any higher than that, because then you run the risk of that balloon pump engaging one of the arch vessels and inflating that balloon in your common carotid artery would not be a good thing. things that can blink more too. We still see this occasionally, maybe 2 or 3 times a year. This device, and it's in the handout, was designed to be a temporizing measure in patients who came in with portal hypertension and bleeding esophageal varices. And what it does is you put the tube down into the stomach where there is a balloon that you inflate. And when that balloon is inflated, you pull the tube back up against the GE junction. And then you inflate the esophageal balloon so that it compresses the varices. And you can walk through the ICUs and tell who's got one of these because they all have a football helmet on with a face guard, and that tube is taped to the face guard so that it can't move. Don't see that so much anymore since TIPS came along, but it's still there occasionally. The intraosseous infuser, that's this guy right here. It's that little half-moon shaped radiopink line, and this is actually where the IV tubing connects to the intraosseous infuser. And those things will take a surprisingly high rate of infusion. Complications. Okay, look at this patient. See where the endotracheal tube is?
Mm-hmm.
And that's what it looks like 30 or 40 minutes later. The endotracheal tube is not only in the right mainstem bronchus, but it's past the origin of the right upper lobe bronchus. So this is complete collapse of the left lung, and the right upper lobe is going down. So what you have is the tidal volume on the respirator that's designed for 2 lungs going into the right middle lobe and the right lower lobe. And that's not going to be a happy outcome. This is the example I was going to show you earlier of the balloon on the endotracheal tube. That's way overdistended. Can you imagine what that's doing to the airway, which is this column of air here? Can you all appreciate the difference in magnitude?
Yes.
This is the nasogastric tube that has been, it looks great on my monitor. I'm not sure how great it is for you all.
I can see it.
Okay, so here's the nasogastric tube coming down right into the right mainstem bronchus and the bronchus intermedius.
What about the swans on that one? Should it be curled?
Swan is in the main pulmonary artery, and you'll find differences of opinion on that. I was taught as a resident that you don't leave it in the main pulmonary artery because as the heart beats, it causes the catheter to do this. And in the main pulmonary artery, you're right on top of the interventricular septum, and so you run the risk of inducing an arrhythmia. Our cardiac surgeons could care less. They leave it there all the time, and they don't seem to have any problems. So I guess it's more of a theoretical problem than a real problem. So that's okay where it is. If you've not seen one before, this is Venatech IVC filter, but I'm showing you the film for this. This is the radiopaque tip on a Corpac feeding tube. What do you think about that? Is that appropriately positioned?
No, sir.
What's wrong with it, man?
It's going to the right mainstem bronchus.
Well, no, we're in the abdomen here. This is liver here.
Oh, sorry, it looked dark.
Yeah, well, it is. The whole film is dark.
And the dialhoxid is supposed to be in the second portion of the duodenum?
Yeah, the question is, can they advance it from this point? Well, our resident said,
peristalsis, doesn't it?
What's that?
Will it peristalse then?
Our resident said, yeah, it's okay, go ahead and advance it, but if you look at the way it's oriented, it doesn't look quite normal. So they advanced it and got this film. Now where is the tube?
Did they perk something? Did they go through something? No.
This is the film they should have gotten originally, and the tube comes down here. You can see it goes
it's in
around And that's in the
Posterior.
posterior costophrenic angle of the pleural space, because they didn't
They would
follow the
just keep shoving
protocol
that
and
thing
just
down.
advanced the tube right out through the lung. And this is just another example of the same thing. Here they sort of followed the protocol, so they detected the fact that the tube was in the right lower lobe before it actually got out into the pleural space. This is a patient we saw a few years ago, and I can't remember just what all the underlying lung disease is. This may be resolving pulmonary contusion, but he had surgery, and I think it was for a traumatic rupture of the aorta. He's got a feeding tube in it, and we saw this, and somebody raised the question of, could that be a tooth? Yeah, I suppose. So we called the physician taking care of the patient and asked him, did you have trouble intubating him? Did he have a big face bust? A lot of problems? And he said yes to both. That he had a huge face bust, there were a number of teeth were missing, and we had trouble intubating him. So we needed to know where this was, if it was in the airway or if it was in the esophagus. So this is what I had the technologist do. I had them shoot an LAO, so you can see here is the endotracheal tube, and there is the feeding tube. And this is the image that I would have recommended in that feeding tube protocol rather than an AP film. Because if you shoot this, if it's in the airway, it's going to project right over the endotracheal tube. If it's in the esophagus, it's always going to be posterior. And so even if the radiopaque tip is proximal to the end of the endotracheal tube, you'll still know. But what happened to our tooth? We don't see it.
He was lying on it.
No?
Nope, it's on his chest.
Come back and look at this again. See a little thin white line here and here and
syringe.
Oh,
that's exactly
yeah.
right.
Yeah.
It's a plastic syringe, and the only thing that's radiopaque on it is the stopper.
Yeah.
Which, from a practical standpoint, when I'm talking to our house staff and medical students, the point I make to them is you have to have the nursing staff in the ICUs get all the extraneous stuff off the patients, because our technologists are not, nor do you want them to go in and just start moving things around on the patient, because they are all deathly afraid, as I'm sure you all were when you were doing it, of dislodging something that's important to the patient. So that's responsibility for the nursing staff. Okay, here is a patient who's got a Swan-Ganz catheter in it. You see where that tip is?
Mm-hmm.
You do my thirds, way too far out. But the question now is, what is all this opacity down here? And this is something you probably have not heard about before or not familiar with, but the two most dreaded complications of malposition of a Swan-Ganz catheter are pulmonary artery rupture and a pulmonary infarct from occluding the pulmonary artery. And that's what's occurred here, is they didn't pay attention to where the tip was, and they just automatically, reflexively inflated the balloon, but the tip was further out than the caliber of the balloon, so it ruptured the pulmonary artery, and this is all blood in the lung. The point I make with this case, and this patient died from this, the point I make to the house staff and to our residents is you have to think about what you're going to do if this occurs before it happens, because once it happens, you don't have time to fiddle around and say, well, let's call VIR and have them embolize. That's not what you do for this. You call anesthesia, they put in a dual lumen endotracheal tube, and they balloon occlude this airway so it doesn't spill blood over into the other lung, which is what they're going to need to live on, and the length of time it takes them to get to the OR to get a lobectomy done. That's how you deal with this complication. You can't fiddle around calling VIR and expect them to balloon occlude that pulmonary artery segment, because the patient will be dead before you ever get them up there and you get the tech in and you get yada yada going on. And this is another patient with a malpositioned Swan-Ganz catheter, was transferred into us from an outside institution. Look where that tip is. And this is what that looked like the next morning, and this is pulmonary infarction. They didn't blow up the balloon, but they occluded that pulmonary artery. And it's the same thing physiologically as having a pulmonary embolus. This is a little bit tougher to see. This is a patient who's had an introducer sheet here placed, and the tip is right here. And the point I make to our residents and to the house staff is, if you're replacing catheters, you have to know the vascular anatomy well enough to know whether or not the catheter you've just placed is going in the appropriate spot. And for the residents who are reading these films, you have to know the vascular anatomy well enough so that you can tell the resident where this is likely to be if it's not in the appropriate spot. In this particular case, that catheter had gone through the subclavian vein, through the subclavian artery, and the tip was in the right common carotid artery. And they had to take the patient to the OR and put him on bypass to repair that. So the key thing was recognizing that this is not in the normal venous course, and you don't just willy-nilly start pulling the catheters out until you know exactly where it is. This is baseline film on a patient in the medical intensive care unit. They're intubated, they've got this gastric tube down, and the next day they have a dialysis catheter in place. But there's a little subtle change up here at the right apex. Let's back up one. Look at this area up here. It looks pretty similar to the left side. But now, there's some extra density up here. And one day later, it looks like this. So who can tell me what happened?
Bleed?
Yes. They sucked the carotid artery when they were trying to place the catheter, didn't recognize that they had done that, did not get hemostasis, and this is all extrapleural hematoma. And you know it's not venous bleeding because it's pushed the catheter out laterally and it's displaced, actually dissected the parietal pleura off the chest wall. Venous bleeding won't do that. It will tamponade before it ever gets to this point. The bleeding will stop. Free air. Ideally, in the best of all possible worlds, if a clinician has a patient that they're worried about an abdominal process and they want to exclude free air, they would have the nursing staff put that patient into the left lateral decubitus position while they're calling down the order for the abdominal film. So by the time the technologist gets up there to do the films, the patient's been in the decubitus position for 10 minutes. Any free air has had a chance to percolate up over the liver margin. I don't think that happens all the time. Here's a patient who's got obvious free air. This is semi-erect, and you can see air outlining the gas-filled stomach and over the liver margin. Not quite so obvious on this case, but there's too much lucency down here. Your clue is generally that the density in the left upper quadrant and the density in the right upper quadrant should be about the same. If they're different and the soft tissue density on the chest wall is the same, then there's air there. Also, if you look down here, here's what we call the double vowel wall sign, and I'll cone in on that. This is air in the lumen of the bowel. This is air outside of the lumen. Can't see that bowel wall unless there is free air. The other clue on a supine film for free air, if you ever see a triangle of gas lucency, that's got to be extraluminal. Because if it's in the lumen, it's going to be either a circle or an ellipse because it's a bubble in a fluid-filled structure. But if it's outside of those fluid-filled structures, and you've got three different loops making the three edges of the triangle, it will look like that. So that's a clue to free air on a supine film. When they set this patient up, it was obvious that there was extensive amount of free intraperitoneal air. see, why did I put this one on? Oh. This is what you're looking for in the decubitous position. And it's important to be able to see the diaphragm and the lung markings out here at the CP angle. And this drives me absolutely crazy, and I fight with the techs every weekend I'm on call, because they will overrange this area and send the film through anyhow. And if that's overranged, if this is all black, I don't know if it's black because it's overranged or it's black because there's free air there that I can't appreciate. I've got to be able to see the diaphragm and the lung markings all the way out in the CP angle to know if this is all white down here, that there's no free air, okay? Pneumatosis, not something you have to deal with very often because as a rule, clinically, it's more apparent that your patient has ischemic bowel than it is radiographically. But it's important to recognize if you get a radiograph, if you see linear lucencies like so, or you see model lucencies like this in the distribution of small bowel, that's got to be air in the wall of the bowel, because in the small bowel, the fecal stream is liquid. So you won't have model lucencies like you would if this was stool in the colon, which it might be mistaken for. This is a patient who was in a bad motor vehicle accident, had severe abdominal trauma, went to the OR, had a splenectomy and a partial hepatectomy, which is what these clips up here are. And we were looking at this film and we were a little bit alarmed by this linear lucency and these branching lucencies here in the right upper quadrant. So the house staff ordered this film, and I'm not sure exactly why, because it was less than 10 hours since they had taken him to the OR, so you would expect there to be free air in the abdomen. But look at this. He's got lucencies down here on the dependent surface of the bowel wall. If you see lucency on the dependent surface on the fluid-filled bowel loop, it's got to be in the wall. So they took him back to the OR, opened him up, and he had infarcted his entire GI tract. He had traumatic thrombosis of his superior mesenteric artery, superior mesenteric vein, and inferior mesenteric artery. They closed him up and he expired in the PACU. Pneumothorax. This is another area where it's a constant struggle with the clinicians. They'll order an AP supine film or an AP semi-erect film to rule out pneumothorax. Can't do that. If you really want to rule out pneumothorax, you've got to do a cubitus film with the affected side up. There are some things you can look for in a supine film that would suggest pneumothorax. Now, obviously, if you have a tension pneumothorax and things are shifted to the other side and you've got all this lucency, that's not a diagnostic dilemma. You know, I'd probably take a first-year medical student and get them to make that diagnosis. This is a different issue, though. What about this edge we're seeing right here?
It could be a skin fold.
Excellent. And you know that because, and this is another point about radiographic technique, Murphy's Law says if there's one spot you need to really visualize well, it'll be right underneath where the EKG electrode connector is. But if that were out of the way, you could see that this line crosses the bony structures of the thorax. Other thing is, if it's a supine film, the air should be down here because that's where the high point in the chest is. So that's where the air will preferentially collect, not out here laterally. Here's just another example. Same thing. Notice also that it's not as lucent as you would expect if that were really a pneumothorax. This particular case, we see probably at least once a year, something like this. See this line right here? Mm-hmm. House officer saw that, didn't show it to a radiologist, didn't ask any questions. So the next film we get, they put in an arrow cap, which you can see right here. Look at this. Now, the only way that happens, the only way you get air in the subcutaneous tissues is if you have a hole in the chest wall and the pressure in the pleural space is higher than atmospheric. This particular catheter is placed percutaneously. It's a one-step device. It's got a stylet in the middle with I think it's a star-shaped point on it. What they do is they walk it over the top of the rib, and then when they think they've gone into the pleural space, they advance the catheter off. The problem is if the lung is up against the pleural surface and you advance the catheter into the lung, you will get air back just like you would if it was a pneumothorax. And when you advance the catheter, you will create an 8 French hole in the lung, and now you do have a pneumothorax, and you have pressure in the pleural space that exceeds atmospheric pressure because the patient's intubated, and so it blows air out into the chest wall. So at least once a year, we see a house officer place a chest tube for a skin fold. Okay, this one, remember the comment I made a little bit earlier about the comparative density between the left upper quadrant and the right upper quadrant? The density of the soft tissues looks about the same, but it's much more lucent here. This is what we call the deep sulcus sign. This is air in the pleural space. It collects intermediately. And that's why there is a difference in density. And when you sit the patient up in a semi-erect position, maybe it's a little easier to see there is the pleural edge along here. Swan-Ganz catheter, endotracheal tube, pericardial drain, anterior mediastinal drain. That's the pre-op film here, and this is the post-op film. Is that the same patient?
No, because of the valve and all that stuff.
Well, one doesn't have a pacemaker. The post doesn't have a pacemaker.
Yeah.
That's not right.
Yeah, these guys don't come out unless you do a heart transplant. So after you verify that it is indeed the same patient, you know that this person had a heart transplant, because the valve can be replaced, but it doesn't disappear altogether. Take that back. St. Jude makes a variety of prosthetic valves that has no radiopaque markers whatsoever. And so if somebody gets one of those, you have to be told by the surgeon what they put in, because it'll be you won't know. But this, typically what you see is if these have been in for a long time, they won't be able to get them out, so you'll see a little remnant of the pacemaker or the ICD electrode where they've just cut it and then they've done the heart transplant. This is a portacath that's been placed the right subclavian vein, and it makes kind of a U-turn right here. You have to recognize that that is likely to be in the azygos vein. It doesn't look like there's a whole lot of catheter there until you do this, and you see that actually that catheter extends quite a ways back in the azygos vein, which is an arched structure. So if you see a catheter that is coiled on itself right in the region where the azygos vein is, which is right over the top of the right main stem bronchus, it's in the azygos vein. Can you leave it there? Probably not. You got to ask yourself, why do we put central venous catheters in the first place? We do it because we're giving something that may be toxic or harmful to the endothelium, so we want high flow rate, lots of blood to diminish the concentration. Azygos is a low flow venous system. So the likelihood is if you infuse anything there, first of all, it will be going in counter to the direction of flow. It's likely to cause endothelial damage and thrombosis. I don't know if I can do anything to adjust that, but maybe you can see there is a PICC line that comes here and then it's coil
Cool
right
back.
there in that same spot. And that's in the azygous vein. Here is a catheter put in from a left jugular venous approach, same thing. It's coiled upon itself right in the region of the azygous vein. This is something you probably have not seen before. Pacemaker put in. We've got the lead here in the right atrium and the lead here in the right ventricle, but how did it get there? This is what's called an Ant Mini in radiology. If you haven't seen it before, you can't figure out what it is. But once you've seen it and you know what it is, you'll recognize it the next time you see it. Embryologically, there is a stage of development where you have paired cardinal veins that form superior vena cava. And normally, the left side regresses and you're left with a right-sided superior vena cava. If the left side doesn't regress, then you're left with some anatomy that looks like that, although this can be missing, so that the left and right superior vena cava drain the ipsilateral head and upper extremity. And that's what you're seeing here. This patient has a persistent left superior vena cava, which drains into the coronary sinus, which drains to the right side of the heart. So there's no right to left shunt, there's no desaturation. Physiologically, these people are normal. The incidence of this anomaly is about 0.3 to 0.5%. So it's just common enough that you're going to encounter it at some point. But I got to tell you, it's a whole lot of fun when you know about this and you see an anesthesiologist come running out of the PACU because they just put in a subclavian line and it's diving down into what looks like the left lung and they haven't got a clue what's going on. And that was the first time I saw one on call, just that scenario. And this shows you the course of that as it comes down and drains into the coronary sinus and then over to the right side of the heart. Okay, that's a quick and dirty trip through the wonders of ICU radiology. Questions for me before I show you some hard copy films? Okay, let's take a 5-minute break. Be back here at say 25 after 6, and then I'll show you some films, and then we'll wrap it up by 7 at the latest.
Do you guys know where the bathrooms are?
Oh, that would be helpful,
Go
wouldn't
out of the
it?
hallway, make a left,